Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Welcome, everybody, to the Functional Medicine Discussion Group of Santa Monica. I've been running this event for the last 9 years. I'm not sure what we're going to do going forwards. We've had a tough time since the pandemic getting everybody to show up. So we may have to rethink how we do things. But as of right now, this is the last event for 2025 for sure. And so if you're a practitioner and you're listening to this and you're not on our closed Facebook page, jump onto the Functional Medicine Discussion Group of Santa Monica closed Facebook page. I post scientific articles on a regular basis, and we have discussions about cases, etc., so we can continue the functional medicine discussions there. Also, I'm recording this, and this will be part of my weekly Rational Wellness podcast. So if you don't subscribe to that, listen to that. You can watch it on YouTube. You can listen to it on all the podcast apps, and if you go to my website, you can get the complete show notes. So today is the second annual Dr. Howard Elkin Memorial Preventative Cardiology Lecture. As most of you know, Dr. Howard Elkin was a beloved member of our functional medicine community, and he spoke regularly at our meetings. He attended most of our meetings. He was a good friend of mine. He worked out of our office. Last year, he was due to speak in August, and he passed. And so I gave the lecture using his notes as the first annual Howard Elkin Memorial Lecture. And so today we have Dr. Matthew Budoff, who's a preventative cardiologist. He's published hundreds of scientific studies, and he's also an expert on cardiology scans like the coronary calcium scan and the CT angiogram with artificial intelligence. If you're not aware of what those scans are, they're very important ways to not just get a sense of whether or not you might have plaque, but actually seeing the plaque and seeing what state it's in. So, Dr. Budoff,
well, thank you.
Thank you so much for joining us.
New Howard, certainly an honor to speak at a conference in this name. I'm not really a formal functional practitioner. So I do a lot of therapies that are considered functional in some ways, and I certainly incorporate a lot of that into my practice. I call it blended practice. But I did want to focus on lipids. I think there's a lot of great data out there on alternative ways of lowering LDL, like treating patients with hyperlipidemia. I do think that lipids are generally a bad thing, although I just finished a keto study, which I'm not going to decide any here, but the keto diet, which did show very high LDLs. The hyper-responders or LDLs were in the 250, 300 milligrams per deciliter for LDL, and they didn't have much changes in their plaque from a prospective 1-year study. But we'll leave that one off. But I do think lipids are important. I do think generally that people are very high or elevated LDL cholesterol offers us an opportunity to reduce cardiovascular risk. This study is called the Injury Offer Study. It's probably one of the most important studies in cardiology and preventive cardiology because it shows us what the contributions are of different modifiable risks towards heart disease. And you can see that they calculated, this was based on 30,000 patients, that the attributable risk adjusted for the risk factors, if you address all these things, that you can reduce risk by about 90%. There's still a little bit that we can't do. We can, I don't know, maybe changing your sex does change your risk. I don't think so. Certainly changing your age. not possible? Is it why about it? And your genetics we can't change, but everything else we can affect.
So when you talk about lipids, is this based on a basic lipid profile or?
It's a basic lipid profile. This is not
Right. So what percentage better attribution would you get if you did a more extensive advanced lipid profile? You looked at homocysteine, you looked at omega-3s, etc.
I think you're probably looking at maybe 70% of the answer.
Okay.
This is just basic LDL, HDL, triglycerides, just the very basic panels that we historically look at. Importantly, psychosocial issues are a big deal. Stress, depression, anxiety play a huge role. But, things that we normally targeted very aggressively, things like smoking, it's important to get people to quit smoking, but less even than just basic lipid panel, and hypertension, much less. So not to say that we shouldn't be getting people to quit smoking and controlling their blood pressure, but I think lipids represent the biggest opportunity for us to change people's outcomes. So understanding that, we have alternatives to statins, and this is one of them that's relatively new. It's called Bempadoic acid. It's sold as Nexletol. I'll show you this combination pill with ezetimibe as well that's available. So statins work here in the liver. This is the liver, and this is where we create cholesterol. So normally in the liver, almost 85% of your cholesterol in your body is manufactured in your liver. So your liver takes citrate, goes through a bunch of steps, about 7 enzymatic steps to create cholesterol. If we block cholesterol, here the HMG-CoA reductase, the statins, we slow down this pathway and we decrease cholesterol. But there's another enzyme now that we can target called ATP citrate lyase. And ACL, or ATP citrate lyase, is an enzyme that has different properties and different side effect profiles than targeting HMG-CoA reductase. It also slows down the process. It also lowers cholesterol. It can actually be used together with a statin. It kind of two hits on your system and slow down the process even more. The reason that I think statins cause a lot of issues is because they're active compounds. They're not a prodrug. They're active compounds. They can cross, most of them can cross blood-brain barrier and all the other barriers that you can think of, and really penetrate muscle and tissue. And when they get into the skeletal muscle, which they can do quite readily, they also block HMG-CoA reductase and cause problems. We also have to get statins deplete coenzyme Q10 and thus CoQ10, which I'm not going to talk about tonight, but we actually did a very nice study showing that it improves endothelial function. But statins cause muscle toxicity because it's an active compound. Bempadoic acid is an inactive compound, so it needs to be activated. And the only place we know that it has any significant conversion is in the liver itself. It gets converted by this enzyme, it gets activated, and then it blocks cholesterol synthesis. It's inactive in the muscle, so it cannot cause muscle toxicity. So for those patients who have muscle toxicity from statins or don't want to take a statin, Bempadoic acid decreases cholesterol synthesis without affecting the muscle. The other major factor with Bempadoic acid that people don't recognize is that it not only has all the anti-inflammatory properties of a statin, it actually might be more potent as a side effect of lowering inflammation, but it actually reduces diabetes. It's the only lipid drug we know of that actually improves diabetes.
Whereas statins increase diabetes, right?
Worsen diabetes, and the CT and the PCSK9 injectables also cause more diabetes. So we have a decrease in diabetes, a decrease in inflammation, and no muscle toxicity. So I think for those patients who need pharmacological therapy, Nexletol poses a nice benefit. I'll show you the outcome data in a moment.
Another complaint that some patients have is brain fog, and there seems to be some data that, at least in some patients, that statins might be negative for the brain.
Yeah.
What about Bempadoic acid on the brain?
So statins definitely have a small but measurable effect on in some patients. I don't think it's most, and I know most cardiologists are taking a statin, and most of them at least seem pretty clear to me. So I don't think it's everybody, but who knows? Maybe they're a little sharper before they start. But Bempadoic acid has not been shown to have that any activity in the brain. It just doesn't. Because it can't be activating the brain, so it should have no off-target effects. That's the way we would think about it. So the problem with Bempadoic acid is that while it lowers LDL, it lowers it by about 25%. It's not as potent as statins. Statins can lower LDL by 40 to 50%. Rosuvastatin, for example. But it does have a very nice effect on HSCOP. So as an anti-inflammatory, it has a robust benefit, and this is on top of a statin. So despite or improved on top of a statin, it lowers inflammation, which I think is a good thing for the body. And it can be combined with ezetimibe. Ezetimibe works completely differently. It blocks absorption of cholesterol into the body. So you block reduction with Bempadoic acid or a statin. You block absorption with ezetimibe, and you end up with a nice adjunctive benefit. And now when we add the two together, we get about a Nexlizet instead of setting it inside the pill. So it's a single pill. It's the same price as Nexletol. It comes with a copay card, so I think it's for most patients who have insurance, it's $5 to $10 a month. But it does lower LDL by about 38%. And this is on top of a statin. If statins are not in the mix, it's actually a little more potent than that. It's probably about 45% LDL. So this becomes statin-esque as far as its LDL lowering without the brain fog, diabetes, or muscle toxicity. So just from a pharmacological perspective, this is a once-a-day pill. This is a decent solution. We did an outcome study. I was part of this. I was one of these principal investigators of this CLEAR outcomes trial. We randomized patients just to Bempadoic acid or placebo. We didn't use the Zetia part because we want to see what just this drug did separate. But I don't use this drug without ezetimibe in most patients unless they don't tolerate it. And it did lower events. 3-point MACE, which is our primary endpoint, MI, stroke, and death, reduced by about 15%, was significant, was statistically significant. Heart attacks reduced about 23%. And revascularization about 19%. Do you choose? So a good benefit, a decent benefit, and certainly proven outcomes now with Bempadoic acid. If you add ezetimibe, which also has outcome benefit, you're obviously going to do better than this. So what about other therapies? Well, fish oils, and in cardiology, we don't think that the mixed EPA DHA has as much benefit as pure EPA, at least the cardiovascular benefits. So DHA for brain development as a young person or for eye development, very, very important. But DHA disrupts the membranes and can decrease the efficacy of therapy. And that's been shown now in a few different ways. But pure EPA has always consistently shown benefit. I'll just show you 2 of the trials, but there's now 9 that show benefit if you use purified EPA, which is one of the 2 omega-3s, but it's only one of them. So this is, this is EPA 1.8 grams. They did have statins on board as background therapy. The FDA requires background therapy of statins for the clinical trials, so we don't have any monotherapy with EPA outcome studies. But in this trial from Japan, the JELIS trial, EPA lowered cardiovascular events by 19%, which is pretty robust on top of a statin. This was actually the first study ever in all of cardiology to have people on a statin and improve outcomes further. Because we had great data in the early days with niacin, but when we added niacin to a statin, we didn't see as much in that reduction. We had great data in the early days with fibrates, like gemfibrozil. When we added it to a statin, we didn't see that same benefit. So we think that some of the statins might have taken away some of the risk, and then the residual risk was lower, or these agents overlapped too much with statins and didn't really show the same benefit. But despite being on a statin, when you add EPA, you get additional cardiovascular benefit.
So did you say that DHA interferes with the action?
Yeah, so DHA, and I don't have the mechanistic slides here, but DHA, we know from at least from a cardiologist point, it interferes in the lipid bilayer, and it makes the lipid bilayer more permeable to things like oxidation. So, because we've done now, I don't have the slide, but there are nine outcome studies with EPA plus DHA.
Right.
And all 9 are negative. This shows no adverse benefit. We have 9 studies with our EPA, some anatomical studies and 3 big outcome studies, and all of them are positive. So we kind of can infer that DHA must take some of the benefit out.
I'm going to suggest that you consider at some point doing a study with EPA and DHA, and also include tocotrienols, which are a vitamin E compound that reduces the oxidation.
No, that's a great idea. I think we need to be smart about our antioxidants. We didn't do very good studies. I wasn't involved, but we didn't do very good studies in cardiology of the antioxidants. We did a couple studies, just kind of generic antioxidants, and didn't see a big benefit and kind of abandoned that thought process. But I think oxidized LDL is bad. And I think if we can reduce oxidation, we're going to be in a better place.
They clean up DHA to the brain.
Yeah. So I think for the brain and for the eyes, DHA is very good. I think once you're fully developed, though, I don't know if you need more. I don't know how it works in adults, but I think for the growing people, DHA is very, very important. So in children, in infants, and remember, there's very few pills that you can give pregnant women indiscriminately, and one of them is fish oils, because it's so important for them and for the development of their child. Right, so there are some prescriptions that are legitimate to give to pregnant women that we think are actually beneficial and have no risk upon. So we had that trial from the Chelation trial, but that was a Japanese trial. Like, for some reason, the FDA just will not accept trials that don't have some U.S. populations, even though when we do U.S. studies only and we export the data, we expect everybody to accept our findings. So it's a little two-sided, but so they made us do this trial, and I was one of the principal investigators for the Reduce-It trial. So the Reduce-It trial took over 8,000 patients. They were on a statin because the FDA required statin background therapy, and then they had mildly elevated triglycerides, and we randomized them to 4 grams of EPA. Icosapent is a precursor of EPA, or just placebo, and followed them for the next 5 years. And at 5 years, this is the statin plus placebo arm, and the LDL was well controlled. It was well below 100 milligrams per deciliter, and they still had 20% event rate over 5 years. When you look at when you add placebo, you reduce their risk by 26%. So icosapent, this is 2 of the trials, Chelation and Reduce It. There's a third outcome study called Respect EPA, which, because nobody does, and they did in Japan, that also showed about the 22% benefit. So 19, 22, 26% benefit. I did a mechanistic study, and these are just individual outcomes, but you'll see it's very consistent. It lowers deaths by 20%, and lowered stroke by 28%, and lowered MI by 31%. Across the board benefits. Notice how quick they looked at. There was benefit with being on EPA. So I did a similar study, a mechanistic study using CT angiography. So non-invasive angiography, we start an IV. We give a little bit of dye, and he takes his pictures, and we make 3D images. Dr. Elkin was a big fan and ordered a lot of them for his patients. That's how I got to know Howard. But the Evaporate study, what we did, and I was the primary investigator for this trial, was same entry criteria. Triglycerides a little bit up, LDL control on a statin, and we looked at 4 grams of icosapent, again, EPA. And this time, this is statin monotherapy. This is progression of Apthorel above the line in red. And in blue is the combination of EPA plus statin. And you can see across the board regression of every plaque type that we measured. Calcified plaque doesn't really change when it didn't change
Over one period of time.
over 18 months, 1.5 years. Please.
How is the EPA administered in those studies? Is this a pill? Is something you take with?
There's a gel capsules. Yeah, two BID. They're 1 gram each. So take 2 in the morning.
On empty stomach or
Oh, it doesn't matter.
doesn't matter?
Yeah.
Okay.
Yeah, and they're gel.
Refined, so it's not straight fish oil.
It's refined. There's nine processes going from fish to purified EPA. It has on average 98% pure EPA in the capsule. If you were to get, let's say, Mega Red or one of the other dietary supplements, they're not, nobody's so kind of foreseeing they have production, but Mega Red is a 1,000 milligram capsules has 300 milligrams of EPA and DHA and 700 milligrams of other. I don't even know what it is. This has 980 milligrams of EPA out of 1,000. So might have 20 milligrams of other. So it's much more purified. It's also done in a highly controlled environment with no oxygen, so that they don't get that antioxidant, and it doesn't smell, which I think demonstrates the lack of some of the oxidation and oxidative properties that we get, why fish becomes odorous and more malodorous as it ages. So it's an odorless capsule. If you were to break the little gel cap and take out the liquid, it's not only clear, but it's also odorless. And we'll talk more about odorless in a moment when you talk about garlic, because it's another process that is been shown to be able to purify garlic supplementation as well. Yeah.
I know that's testing.
This?
The one that is great.
Oh, this is called Vasipa. Oh, yeah, icosapentathable Vasipa.
Prescription claim.
Prescription, yeah. They have copay cards. It's literally cheaper than, for most patients, it's cheaper than buying a big bottle of fish oil tablets, because I think it's $8 with a copay card. But even though it's a prescription, if they have PPO or HMO, they can get coverage. And there is a generic formulation as well.
There is.
There is a generic formulation of Vasipa, so it's not, you don't have to get the name brand. And so it's definitely something that I use in my practice. We only studied it in the setting of high triglycerides, elevated triglycerides, because we always used to use fish oils as one of the ways of lowering triglycerides. But we don't really know if your triglycerides are totally normal, if you would benefit or not from this treatment. Because I just want to show you testosterone just as a little bit of a warning. I'm a fan of testosterone with treatments, but I literally saw a patient this morning, and he came in and his calcium score went from 100, like 120 to over 400 in 3 years. So he tripled, literally. It went up 100% per year for 3 years in a row. And he's healthy, and he's fit, and he works out, and he's thin, and he says he eats well, and he exercises a lot, and he couldn't understand why. And he shows me all his labs, and his inflammation is normal, and he doesn't have diabetes. His A1C is perfect, and his LDL, his lipid profile is excellent. But his testosterone has been running about 1,500 for 3 years in a row. And I'm like, what's going on? Like, a lot of testosterone. I did this study, the testosterone trial, and we showed that if you overplate testosterone, this is progression of testosterone, of plaque. All 6 types of plaque got worse. This is placebo. So it got worse more than placebo, except for the calcification. It promoted more non-calcified plaque, more total plaque, more low attenuation plaque, fibrofatty plaque, than Barker's plaque. It actually increased the calcium score as well. Dense calcium is just a CT angio subparticle of calcification, but instead, clearly, like, why would you take this much testosterone? I mean, I realize some people want to, get really muscular or whatever. And he says it wasn't libido. It was that he was trying to get his free testosterone higher, and he couldn't get it up until he was repleting himself with a huge amount. So I recommended that he goes down to 700 or lower, just because I think he's driving, because the only risk factor he had was this crazy testosterone level. But I do think he was over-repleting his testosterone, and I do think it could cause significant issues
Do we know what the mechanism is? Is it because of a decrease in HDL? Does it increase iron? Do we know what the particular...
I think that's a great question. And I'm not sure we know all of the effects of testosterone. It was thought when we did the testosterone trials, which was 7 randomized trials sponsored by the NIH, taking men with low testosterone and giving them androgel. The hypothesis was it was going to do a lot of good. It was going to help with bone density. It was going to help with muscle mass. It was going to help with libido. It was going to help with depression, and it was going to help with plaque in the coronaries. The endocrinologists fully believed that these patients would be better, and they got worse. And I think we just take a 75-year-old man and turn them into a 35-year-old man. Maybe a little bit too much, but I don't know if we know the exact mechanism.
Lower level.
I think a lower level is safe. At least we have the Traverse trial that shows that it's safe. And I think to address symptoms, just like I use hormone replacement therapy in my postmenopausal women, I can use it to to help them with their symptoms. I keep the doses lower than we've historically used, and we don't see all of those negative effects. I think the same is true of testosterone. We don't need to turn a 70-year-old woman into a 30-year-old woman with high hormone levels. We need to get her back to where she's feeling better and not losing bone and other benefits of hormone replacement therapy. I think the same is true of men. But I think a lot of people abuse it because once they're on it and they're getting more muscular, it's might as well inject a little bit more. And we just know that we know it has a lot of adverse effects because we see all the bodybuilders who suffer long-term consequences.
And you don't see 1,500 testosterone in men who use gel. It's pretty much for injectable.
He was injecting,
yeah.
Right, he said he was injecting 0.2 twice a day, but I don't know.
Wow.
But he said only 0.2. I tried not to say twice a week. So not twice. But yeah, I think he was using more than that.
Right.
We're across the board.
Right.
And I don't know. I don't know his primary. I didn't recognize the doctor's name, but I just told him I think that you have overt proof that we did CTAs as well, and the CT angio got words too. It wasn't to the point where he needs bypass surgery, but in 3 years, certainly looks worse. From his coronaries on the outside, he looks great, and all his labs are perfect. So I was like scratching my head. I'm like, I have no idea until I saw his testosterone levels. And like, I have no idea now of what's going on.
Not everybody here probably knows the difference between a coronary calcium scan and a CT angiogram.
I'm going to show that in a minute.
Okay.
Yeah. I have some studies on garlic where we did CT angio, and I'll show you some pictures. Yeah, but thank you. So let me now go into garlic. I've been studying garlic now for 20-some years. And I actually came into this not as a believer in garlic supplements for heart disease, but this company, Wakunaga from Japan. In Japan, they study this as a pharmaceutical. So it's a pharmaceutical study called a pharmaceutical product in Japan. So we have this aged garlic extract. It ages for 9 to 18 months until there's a certain amount of what they call S-allele cysteine in the SAC in the product, and then they stop aging it and they bottle it or they package it up. Either it comes in a liquid form or they make it into a gel. So they came to me and said, look, we have a lot of trials that show lowers blood pressure, that lowers cholesterol. We want to see if it lowers plaque in the coronary arteries. So I'm like, that's fine. So they paid for a study, and we did a randomized trial. She's actually our second trial. We did a small study, 24 patients. All we did was randomized 24 patients, and it slowed coronary calcium compression significantly. And I was totally surprised because I just didn't expect it to work, but I wanted to give them the benefit of the doubt. And they have a lot of trials in Japan that shows different types of benefit, but they never looked at the CT scan. So we did this study, which is another coronary calcium scan, and we gave them placebo or heroic. They're actually matching. I don't know why they're not matching here, but anyway, this had a combination. This was it was called a folic homocysteine reducing formula as well. It had vitamin B12, folic acid, B6, L-arginine, along with aged garlic.
What was the point of the L-arginine?
This was their homocysteine lowered.
Oh, okay.
So they wanted, this was at the time, that was when everybody was going after homocysteine very aggressively, and This was their formulation. It was a prepackaged formulation.
Okay.
And we did, if you look at lipids, LDL went down nicely at almost 20%. HDL went up quite a bit. And total cholesterol came down. Triglycerides came down as well. But in placebo, we didn't see much action as you would expect. And it had a significant effect on the lipids at 1 year. We looked at endothelial function. So we had this cuff that we inflated and deflated and looked at how quickly the capillaries refilled to show how robust the blood flow was to the hands. And if it comes back nicely, it's healthy. And if we show inflating it, then lowers better for vascular function. It decreased less impairment of vascular function as compared to placebo. So having improvement in overall vascular change. And it slowed coronary calcium. So we did another study, this time in firefighters, again looking at this. This time we used coenzyme Q10. This was another one of their prepackaged formulations of H-garlic plus CoQ10. And we looked at firefighters, and this time we looked at just coronary calcium as the primary endpoint. And we followed these firefighters for a year, randomized either placebo or H-garlic plus CoQ10. Calcium progression slowed by 53% in the patients on H-garlic. We did see about a 30% slowing in the previous study, but this was a little more robust. We did see endothelial function again improved, the vascular health improved by about 90% as compared to placebo, and C-reactive protein went down significantly with this combination of H-garlic and CoQ10. Now, we know CoQ10, I don't have more slides on it than this, but I think it does play a nice supplemental role with lipid-lowering, especially if people are going to use statins. I always put them on CoQ10 as a supplement to help balance out some of that. But I think it does have a number of physiological properties that are helpful. We did see this in the trial. We did see inflammation benefits. We did see benefits on vascular health. And we did a separate study with a company that just makes CoQ10. And we actually showed improvement in endothelial function and vascular health. We again saw this nice reduction in C-reactive protein and another LP-PLA2, which is another what we think is a more coronary-specific anti-inflammatory marker. Both went down with this combination of cardiolate H-garlic extract plus CoQ10. So this combination, nice job on inflammation and a nice job on coronary calcium. It then we moved on to more advanced studies. Now, there's a couple of years later, we now have CT angiography, and I'll show you the pictures, but we can see really, really elegant plaque types. In the study I showed you with the fish oil, the Vascepa and the testosterone, we're done with serial CT angiography, where we inject dye into the coronaries. We can see non-calcified plaque, soft plaque. We can see vulnerable plaque. We can see the artery stenosis. So we get a lot of information.
That's what clearly scan.
It clearly is AI of that study.
Okay.
Yeah. So it's the scan that we use and then send it to clearly AI.
Got it.
Yeah. So this is 72 patients randomized either Kyolic or placebo. This time we just used Kyolic by itself to try to see what the pure effects were of the H-garlic, because if we keep mixing it with other things, we never really know what's causing the benefit. These are some of the sample pictures. The dye is in the center here. It's colorized green just to show the lumen. This is what it really looks like, is white. And we can see the artery, and if there's a blockage, we see a pinch. And then we can see the plaque types, and we can see all of this red and blue stuff is non-calcified plaque and fibrous plaque in the artery. And we cut the arteries into tiny thin slices, less than a millimeter. So we kind of cut the artery like a loaf of bread, very thin cuts, and we measure the plaque on every single slice. So we get plaque at baseline, we get plaque at follow-up, and we can see, are people getting better or getting worse under the influence of drug X or drug Y? And this is very, very popular now We're doing trials with Lp(a). We're doing trials with inclisiran. We're doing trials with PCSK9 inhibitors. We're doing trials with tirzepatide, the GLP-1 GIP combo pill or injection with Lilly. We're doing all kinds of studies with these agents. And basically, if you use cardiolic, total plaque went up a tiny bit over the course of the year, but the placebo group went up significantly more. Same thing with soft plaque with non-calcified plaque. The dangerous plaque, which is a primary endpoint, which is low attenuation plaque, actually went down significantly. That's a big change in low attenuation plaque. And calcified plaque, again, stayed stable. So we've published that work and said it slows down soft plaque and non-calcified plaque. That low attenuation is what we call vulnerable plaque. That got better with garlic. We then did a meta-analysis. This was one of my former fellows, Chris Hom. We did this meta-analysis of all of our studies, and 210 patients total were on garlic. And we can see in the garlic group, the progression, the change over the course of the year was 10 points on the calcium score. In the placebo group, it was 18. So it's about a 40% reduction in the rate of progression of coronary calcium. It didn't reverse calcification, but it slowed it significantly. This was 4 trials out of 4. So every time we did another study in a double-blinded, placebo-controlled environment, garlic slows calcium progression. So I use a lot of this aged garlic extract because of this significant and recurrent benefit, a very consistent benefit that we see.
Pills twice a day?
That's the maximum dose. Yes, they usually go 1 pill twice a day. But we did one of the studies we did at 1,200 milligrams, which is 2 pills twice a day. That would be the most I would give somebody, but you can go up that high.
I was just after the dose, but it's usually 1 twice a day.
It's usually 300 for BID, it's like 600 milligrams a day, but you can go up to, 600 BID, 600 milligram tablets twice a day, 1,200 milligrams. But we did one of the studies, we did it 2,400 milligrams. We did 2 tablets twice a day. It's odorless. It's aged, and so there's no odor. So it's nice because they're getting garlic without smelling like a clove. It has very few side effects. Most people tolerate it. There is a small percentage of patients who will get upset stomach from the garlic, but it's very well tolerated compared to trying to eat a lot of garlic. It doesn't have that same issues. These are the 4 studies. I should say go 1, 2, 3, and 4 for the 4 trials. 7 were happening, but anyway, for the slowed aged garlic slowed calcium progression in the first trial, in the second trial, in the third trial, and in the 4th trial. Consistent benefits across all 4 studies. This is another benefit of garlic. This was done by a hypertension expert in Australia named Karen Reed. She does blood pressure trials, and she looked at all of the different published trials that have ever been done with garlic on blood pressure, and she saw a consistent benefit of aged garlic extract. All of these were aged garlic extract trials. You can see they do a lot of studies. Karen Reed herself in Australia did 4 different trials. And in our studies as well, we saw a consistent effect on blood pressure. So it does lower blood pressure, it does lower LDL, and it does lower C-reactive protein. So, and then it lowers plaque in the coronary. So I think it's one of the nicer supplements, if you will. I think it's people eat a ton of garlic. They don't need it, for sure. And part of the Mediterranean diet, if you're fans, garlic is a big component of that. I think that might be one of the major benefits. It's interesting because garlic goes back thousands of years as a historical supplement. The Olympic athletes, in Olympus, Greece, the Olympic athletes used to use garlic as a performance enhancer before they compete. They would eat garlic where it's a beverage used. So it goes back quite a ways. It's also thought to have an anti-inflammatory, an antiviral effect. Cool. And I think if people are using it in COVID as well to try to help offset some of the viral activity that we saw.
Okay. I'm not sure I caught exact things why aged garlic could be superior to just crushed garlic.
Well, so I think the problem is when we crush garlic or dice it or cook it or saute it, that it might have release different properties. So it's just an inconsistent effect. There was a study done at Stanford where they gave garlic supplements. They gave it in, they used sliced garlic and they put it in sandwiches just to look at the LDL effects, and it didn't have much effect. But it might be the amount, the consistency, how you cook it, how you dice it. This is just a very consistent formulation, but I agree with you. If they're eating a ton of garlic already, I don't supplement that with more garlic. But a lot of patients either can't tolerate garlic or don't like it or just don't eat enough of it. And I think a capsule that gives you the same efficacy as a clove is probably beneficial for them in multiple ways. So anyway, so let me just move on to Reggie's rice. I'm a fan. Please.
Agree with.
Yep.
There's a lot of variation in the quality of commercial garlic. Are there any named brands that are actually available that we can have confidence?
I think this one I like the most. It's called aged garlic or Kyolic. This is the one that I studied. Kyolic, yeah, it's a Japanese. It's made in Riverside, though. It's actually not an import. It's actually a domestic product if you want to support a U.S. But it is, this parent company is a Japanese company called Wakinaga. They're in Hiroshima, Japan. I like this one. We studied it a lot. They have literally hundreds of publications of clinical trials that they've sponsored, whereas Garlic or a lot of these other companies have not. They've never done a trial. They just package it, and they used to have Larry King as the spokesperson for Garlic. But they're still on the radio. I saw them recently. There's a television ad not too long ago. So they're still advertising, but there's just no science behind it. And maybe their formulation is just not as pure, just like the fish oil arguments. If you don't have a purified version, you might be getting a lot of junk. Remember the Food and Drug Administration by law is not allowed to oversee dietary supplements. There was a law passed, I don't know why, but there was a law passed by Nebraska or North Dakota. One of the senators there practiced law passed that says they're not allowed to oversee production of dietary supplements. So all they can do is stop people from making overt claims of health. But if they want to put just talc, in a capsule and sell it as CoQ10, they can do that. And if they want to put vitamin C and sell it as whatever, they can do that. Like there's no regulations on what they're putting in their capsules and no oversight. So it's always a little bit, you have to get the right product, obviously, when we're talking about supplements.
And usually there are third parties.
There are some, but the problem is you pay to play. So the third parties, you pay them to say that your product is pure. So I'm just not 100% sure that's an independent third party. It is a third party, but because you pay them to validate the product, I don't know, there might just be a little potential for bias there. It's not like an independent agency that's doing this naturally. There's a company in Australia that looked at 22 fish oil products and found 20 of them had high levels of oxidants in the capsules and a lot of saturated fat in the capsules. Just a totally independent study of these dietary supplements. But you're right, there are some not consumer reports, but there is a consumer labs, and they do, I think that's it. And they do supervise these. But again, the only ones they supervise are when the company themselves pay for them to endorse, to validate the product. So it just might be a little funny compared to how we think about third party checking on the safety and efficacy of these or purity of these capsules. Reggie's rice has really robust data. Most of it's out of Japan or China rather. So it is a little bit limited in our global understanding of how well it works. But these studies that came out with pretty good high doses of Reggie's rice did show a very, very consistent benefit on LDL cholesterol, a little bit of an inconsistent benefit, but largely a slight raise in HDL, and certainly a very dramatic drop in C-reactive protein. And I think we all recognize that reduced rice is very largely a naturally occurring statin. So this is the statin event. But if you get up to high enough doses, you get very much a statin-like effect. And patients like it just because it's not, I don't know, manufactured by one of the big companies, but some of them, there are statin-induced myopathies that have occurred with reduced rice as well, but it is a way that I get some of my patients who are not on a statin to be on a statin without calling it a statin. So it does work to get them on treatment. So there are outcome studies as well, and the effects are quite good. Now again, a lot of these are well, this is the only one, but these three are comparators. You can see the effect is quite good. It was, again, a Chinese study, and there's always a little bit of question about the accuracy of the data coming out of China. They tend to do things a little bit differently than we do. But almost 5,000 patients, 4.5 years, and it did have a nice reduction in non-fatal MI and coronary death, which was up there with, let's say, the 4S trial, the synthetic survival study, also 4,000 patients, also 5 years, and other similar primary effects. So it does have at least one good outcome study, this Chinese coronary secondary prevention study, but I don't think we have a lot of great data from this is like 20 years old, this study, so I think it's a little jaded.
I think a lot of the studies at 1,200 milligrams are really underdosing, and from what I've seen, I think 24 to 48 is really the sweet spot.
I think I use mostly 2,400. I haven't gone higher, but I agree with you. I think you can get up to that really full effect of the drug, at least with 2,400. You mentioned this vitamin A formulation. It is actually incorporating some of the reduced rice products, and it does have an antioxidant properties for sure, and it does have some inhibition of HMG-CoA reductase, like a statin. So it does have kind of crosses over towards reduced rice, and they're often combined with reduced rice as well. So it does lower LDL, it does lower C-reactive protein. So another option is this vitamin E product, which I think is of the vitamin E antioxidants. I think it's probably the most active of them.
Yeah, Dosage for Health has a product with reduced rice and tocotrienols.
Yeah, combination.
Yes.
Which is the company?
Dosage for Health.
Dosage for Health. Awesome.
Yeah. They've got Barry Tan working with them, who's the guy who really pioneered the tocotrienols.
I'll remember that. Dosage for Health. Okay. And then something that I always thought was going to make a huge splash. There's actually a company that was starting to market this probably a few years before COVID, a few years, about 6-7 years back, and then they just disappeared. I don't think it was due to COVID, but I think they just never really got a foothold here. But citrus bergamot, this is a friend of mine, Peter Tulloch, who's a very well-respected lipidologist. Did this study. He took 80 subjects. He took patients with hypercholesterolemia, and he gave them this bergamot-derived extract. He used Budoff R. He used 150 milligrams of flavanols, which is just a formulation of the bergamot, for 6 months. But he saw very nice drops in. Now I'll show you the benefit in LDL in just a minute. But he not only had a drop in LDL, he had a nice increase in HDL, and it caused a decrease in small, dense LDL particles, which we think are the bad players. And most impressively, the carotid IMT, the carotid ultrasound, decreased significantly from 1.2 millimeters to 0.9 millimeters, which is 25%, in just 6 months. So he said that this bergamot juice extract supplements significantly reduced plasma lipids and improved the lipoprotein profile. And carotid IMT was also reduced significantly over a relatively short time frame. When you look at the effect, even going from the first quartile of theft all the way down to the fourth, there's a pretty consistent effect of LDL reduction, from about 18% down to about 22% LDL reduction. So as a nice, and this was a 6-month trial, nice reduction, and again, small dense LDL particles went down, all the different particles went down.
It was still available.
I think it's out there.
Oh, yeah. We use it all the time.
Formulations. I don't know if this one's available.
Okay, which
I don't know if Turgavid is available.
Okay.
There's other.
Oh, citrus bergamot. Yeah.
Yes.
it's about the formulation.
So this is
No, I don't think so.
And
this is the name of the supplement.
right.
Yeah.
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 There's different
No, I remember
companies that make it.
Yeah.
About it.
No, I think it's a very effective one, and it works completely differently than some of the other mechanisms. So it should be very complementary to other ways of lowering cholesterol. So we have Bempadoic acid, we can add it with ezetimibe. We have the cospendethyl, the Vasipa. We have aged garlic, you have red cheese rice with tocotrienols. We have the citrus bergamot. There's others that I didn't go into today just for the sake of time, but there's very nice data on stanols and sterols, lowering LDL. There's very nice data on niacin, although that's another one that kind of flamed out with when we tried adding it to statins. It didn't seem to have that same benefit, but I still use it for patients with very low HDL. It's a very nice supplement. You just got to go slow because of the flushing.
Significant lowering of Lp(a).
Yeah.
And it's one of the few compounds that can increase LDL particle size.
And no, I think it has great lipid benefits. Unfortunately, the big outcome studies that were done, I think, just recruited the wrong patients. They recruited,
And used the wrong product. One of them had niacin compared with a product that reduced the flushing. That is known to, yeah.
So, and they also didn't take patients with low HDL, which is where I think the benefit is the greatest. They took patients with normal HDL with penicillin. So I know they really proved that Greg, what's his name? I was going to say Greg Stone, but that's not it. Greg. Anyway, the person who did the HATS and the FATS trials, a lot of the early studies, he studied patients with high LDL and low HDL. He showed remarkable benefit, plaque regression by doing coronary angiograms, really nice benefits of adding pure niacin to patients. Unfortunately, when they did the big outcome studies, they studied a different population. It just didn't work so well. It was largely abandoned, but I agree with you. I think it still has some really nice properties, and I still have a good number of patients who take niacin. And then resin binders are actually really interesting because not only do they bind LDL in the gut, but they actually lower glucose significantly. They actually lower hemoglobin A1C by about 20%. They're actually listed in the American Diabetes as an oral hypoglycemic agent, separately from their LDL effects. We don't use them a lot. Cholestyramine. Cholesterol. But they actually lower LDL and hemoglobin A1C quite significantly. So
They're also chelation agents, right? Like the cholesterol stores used for chelation.
there's some chelation. Yeah, I mean the chelation data. The big studies that we did, TACT and TACT2, TACT showed a very nice benefit. TACT2 didn't show as much of a benefit. But again, I think they were somewhat limited by sample size and selection of patients. But chelation's another, oral chelation now agents are a little more robust than they used to be as well back then. Back then we were doing weekly infusions for chelation. So I think that's mostly what I wanted to show you. I'll leave you with this 5,000-year-old concept of probably the English instead of the Chinese, that there's a lot of Chinese medical tests. Superior doctors prevent the disease, mediocre doctors treat the disease before it becomes evident, and inferior doctors treat the full-blown disease. And I think at least in cardiology, we've often waited for patients to present with heart attacks, with severe blockages, needing stents, that I think we do a lot better with prevention. I'm not sure we can totally prevent atherosclerosis and rise to the level of being a superior doctor in the eyes of these Chinese, but I think we can definitely do better than we're doing in most of our practices.
So there's been a lot of discussion in recent years about the endothelium, which is the lining of the arteries, and that being a big issue in terms of plaque formation. And so there are various natural compounds that are fairly popular that can modulate the endothelium. They don't necessarily lower LDL, but they potentially lower the risk for cholesterol to form plaques. And one of them is something called arterial cell. I don't know if you're familiar with that.
Patients that take that.
And then the other product, there's a series of products that are used to reduce, to increase nitric oxide production. So we have products with fermented beets and have nitrates in them that are converted into nitrates, and these have shown a lot of benefit. What do you think about?
I did a study with one of them. I'm trying to remember the name of the one we did with the nitric oxide raising. It was one of the formulations.
Vascuzyme or Neo 40 or
I'll look it up.
Okay.
You know which product it was, but no, I think the endothelium is really important. We know that that's part of the benefit of, let's say, the sildenafil or, Viagra. We did it for pulmonary hypertension because it was effective in the endothelium and it raises nitric oxide. There's a new drug Merck has for heart failure called vericiguat, which ends up raising nitric oxide levels, basically. It's like the GMP. We use riociguat, which is it's sister for pulmonary hypertension, and now they're trying to formulate this new medicine for heart failure. So those are all direct endothelial benefits. But I agree with you. I think endothelium is really important. We have some good data with the garlic. I showed a little bit of the endothelial protection, but doesn't work directly through nitric oxide. But I think that's a really important additional aspect here to think about.
I've seen a photo of a conference, and I don't remember exactly, but they were addressing the glycocalyx in those things.
Yeah, the arterial cell.
That's arterial cell.
Yeah.
That's their.
Yeah, it has this special kind of seaweed that helps to support the glycocalyx.
What are the name of the company? They were like some conference. You must have seen them doing that. It's Dr. Spar is on.
Yeah, I've heard of arterial cell for the glycocalyx, so I'm sure there's other products out there.
Right.
No, there's never just one, but
Yeah, I think brown seaweed is the important ingredient that supports the glycocalyx.
So anyway, that's what I was hoping to share. Yep.
Regarding the CT angiogram, please, number one, how does it stack up against the physical angiogram portion of CLA? And how does clearly compare it to physical angiogram? And number two, how do you approach when to get out? Like you mentioned, someone in the 40s, 50s versus exposing them to petrol radiation.
Right.
Just get it on.
Yeah, so, unfortunately, here on the west side, most of the scanners are pretty old, and the radiation doses end up being pretty high. One clearly takes the existing non-invasive angiogram, the CT angiogram that we do that with an IV, and we take pictures. A lot of those scanners that they're using are just old, and they give up to the amount of radiation. And it clearly takes those pictures, those three-dimensional pictures, and then it does additional analysis, AI analysis, to give you plaque types. So it'll tell you how much vulnerable plaque you have, non-calcified plaque, kind of when I showed you those 6 components. It's the same thing that clearly does, except those took us 3 hours per person to make those measurements. And clearly it takes 7 seconds.
I love it.
Yeah, so, yeah. And I use it to follow patients over time, because if their non-calcified plaque is getting worse, then I know that they're not quiescent in their disease state, and we can look for other targets, maybe with all these different therapies that we can potentially apply for them to them. So I think it's a nice way to track patients over time.
Can you explain the significance potentially of soft plaque versus calcified plaque?
Yeah, so we think the calcified plaque is basically just a marker of how much plaque you have in your body. So it's kind of like almost a bystander. It's the old plaque that's gotten scarred. It's like scar tissue. And you end up with a lot of calcified plaque. But if you have a lot of calcified plaque, you almost always have a lot of non-calcified plaque as well. We think of it as the iceberg, where 20% of the iceberg floats above the surface of the water. And when the Titanic was going downstream and it saw an iceberg floating, it didn't send divers down below the water to say, I wonder if there's anything that could rip the hull. We know that it was there. Calcium score is the same, or calcium scan, no contrast, no IV, just a simple scan, always low dose. can give you how much calcified plaque you have. And that's not the dangerous stuff, but it's a marker of how much dangerous stuff you have. The Clearly exam, the CT angiogram can now tell you exactly how much non-calcified plaque you have, which is this dangerous stuff. That's the stuff that can rupture and cause MIs and blockages. And then you can watch it convert from non-calcified plaque to calcified plaque and become stable. So literally with serial scanning, you can see people's plaque, hopefully, go from a lot of non-calcified plaque to a lot of calcified plaque. So the calcium score goes up, but the soft plaque goes down.
Let's say you're working with somebody who's 30 years old and they have really high cholesterol and the coronary calcium scan, it's relatively low. They get like a 2 or a 5 or something, which is not 0. But should you do the CT angiogram because a calcified plaque is generally older plaque and they might have younger plaques, so they might.
For the younger patients,
right,
middle-aged patients, they could have a lot of non-calcified plaque. In the older patients, it might have less value because a lot of those patients have converted a lot of their calcium or to a lot of their calcified plaque already, and they tend to have a lot of plaque regardless. But I think in the younger patients, they can even have a score of 0, and then we could start seeing non-calcified plaque in younger people. So I do think that holds more value probably where we expect to see more non-calcified plaque of the younger people, women, more so than, let's say, a 75-year-old male. We use the CT angiogram, but not Clearly as much as just to say, do you have blockages? Do I need to think about stents or bypass surgery?
One of the potential benefits of statins is that they tend to cause plaque to become calcified, making it stable. Do we know if any of these natural agents encourage that?
That's a great question. We have some data with icosapent, but we actually just studied semaglutide, which is Wegovy or Ozempic, and it actually converted some of the non-calcified plaque to calcified plaque. So we think that might be one of its mechanisms because it does lower cardiac events by about 20%, and we didn't know how. So that might be part of its mechanism. I don't think we have great serial CT angios in most of these studies, except for Garlic. But we don't have data on the other ones just because we haven't studied them as well yet. And again, it's a problem of these nutraceuticals just don't have the research budgets that big pharma does.
And then, do we know if the patients who are on a statin and they get an increase in their coronary calcium scan, potentially because the plaque is becoming calcified, do we know for sure that their non-calcified plaque is decreasing?
Well, we know that with icosapent and with Garlic because we've done studies. We don't know with these other ones, arteriocel, or some of the other the red yeast rice. Right. Although we just presume since it has a statin mechanism that it would work the same way.
Is it important that a red yeast rice supplement not have lovastatin in it? Because as some of the companies say, we make sure we test ours and make sure there's no lovastatin in ours.
Yeah, I mean, I thought it was like kind of naturally occurring lovastatin. So I'd be worried if they say they have no lovastatin that it'll have no effect.
I think that
how it will work if it didn't have the statin.
I mean, there's similar. It's like that's kind of what it is.
Well, supposed to have 10 more, but lovastatin is my issue.
But I think my understanding is there's this mixture of statin-like compounds, and not having the lovastatin means you're going to get potentially the benefits without maybe some of the negative muscle effects.
Yeah, I would just hope you just have to make sure the LDL comes down.
Right. Yeah.
We have niacin. Niacin had that terrible flushing, so some companies started coming out with different formulations.
Yeah.
Right. Yeah.
And it had no flushing.
Right.
But it also had no
benefit. Yeah.
On the lipids. Right. So there's no flush niacin, but it had no niacin in it.
Right.
So I'd be worried if I don't know, but if you're taking out the active components, get rid of the side effect.
Well, then the product.
The effect anymore.
Well, yes.
I don't know. I mean, they're having that's a placebo. Then.
I've seen a pretty significant lowering with that product.
We talked about tilted and other things that might be in there that might be more similarly beneficial, but I'm just make sure it's working.
Right.
Literally, no flush niacin has no niacin in it. It'll have no effect on LDL or HDL, but they won't flush. So it's like that.
What about the importance of iron levels?
Yeah, I think iron is bad. I think high iron is bad. I've been trying to get a study through the NIH to show that, to do CT angio and then give patients iron infusions or placebo, because some people use iron for heart failure. And I think if you have anemia and you give them iron, that's fine. I think depleting back to normal is probably fine. But I think my theory is that men have more heart disease than women, partly because they run higher iron levels, because women lose iron every month for a long time, and men don't. And I think women tend to run low iron levels, and that might be one of the reasons why men present with earlier heart disease, and why women, when at the menopause and they stop having that iron loss, and that they end up starting to catch up to men. So I think iron is part of that theory. It's not all hormones. I think iron's
often overlooked, and it turns out that 30% of the population has at least one copy of a gene that makes them store iron. The hemochromatosis, there's 3 different hemochromatosis genes. And so we started doing full iron panels on all our patients, and men usually don't get iron measured at all, and a lot of women just get a minimal. And you'd be surprised how many people have high iron levels. I've seen vegetarians with storing iron, and everybody assumed they needed iron, so they just automatically gave them an iron supplement without even testing.
Kind of seen it as a marker of inflammation. I have ferritin.
The ferritin, yeah.
So definitely, and I think people who have high carbohydrate diet, drink a lot of alcohol, they tend to have high ferritin.
That's ferritin.
Maybe we'll change the diet.
It's also an acute phase reactant, so it goes up with inflammation.
Goes up with inflammation.
Ferritin also is reactive.
Interesting. Okay.
So it works both ways. Not those your iron stores, but also can go up and down with inflammations.
Thank you, Dr. Budoff.
It's a pleasure.
Appreciate it. Thank you for making it all the way through this episode of the Rational Wellness Podcast. For those of you who enjoy listening to the Rational Wellness Podcast, I would very much appreciate it if you could go to Apple Podcasts or Spotify and give us a 5-star ratings and review. As you may know, I continue to accept a limited number of new patients per month for functional medicine. If you would like help overcoming a gut or other chronic health condition and want to prevent chronic problems and want to promote longevity, please call my Santa Monica Weitz Sports Chiropractic and Nutrition office at 310-395-3111, and we can set you up for a consultation for functional medicine. And I will talk to everybody next week.